So for this presentation, I looked at therapeutic hypothermia in ROSC patients and the research on how it benefits patients and if it's an effective resource to reduce neurological deficits after a cardiac arrest. So therapeutic hypothermia is also known as targeted temperature management, and it's basically cooling down the body in a controlled and gradual way to induce hypothermia, and this can be done through a bunch of different devices. And the goal of this is to reduce the damage on the brain after a patient experiences a ROSC and after their brain has been deprived of oxygen. So the research done on therapeutic hypothermia is pretty controversial as to whether it's actually effective or not. There's been several studies that have been done that clearly show that therapeutic hypothermia does prevent neurological deficits in patients experiencing a ROSC. However, there's also been data that says that there's no difference between patients that experience a ROSC and have the therapeutic hypothermia and patients that just recover with a normal body temperature. The mechanism of action of therapeutic hypothermia in reducing brain damage is also not completely understood, and we'll explore that in the next few slides. So patients who experience a ROSC will often experience what they call post-cardiac arrest syndrome, and that includes these 3 points. So a brain injury, which is called an anoxic brain injury and is basically cell death signaling within the brain. Then there's also myocardial dysfunction, which is specifically called myocardial stunning, and it's different levels of mechanical dysfunction that occur after a ROSC, such as elevated left ventricular and diastolic pressure. And then lastly, there's systemic ischemic and reperfusion response in the body. So that is global tissue hypotension, systemic inflammation, and activation of clots. So this specifically looks at how the neurological deficits occur after a cardiac arrest because of the anoxic brain injury. So under normal temperatures, the cell's ion pumps shut down, and this causes a buildup of calcium ions and other dangerous free radicals in the brain. And then when the oxygen does return to these cells after ROSC, then these disrupted ion levels and the buildup of the free radicals, it provokes an immune system response, and the cells actually begin to attack themselves within the brain, and this leads to cell death, which causes the neurological deficits that patients experience after they are in cardiac arrest. If a patient does receive therapeutic hypothermia after their cardiac arrest and their body is cooled down, then we will see less effects of this anoxic brain injury within the body. So the calcium ions and other dangerous free radicals levels, they will remain relatively low. And with these normal ion levels, the cell does not provoke the immune response and attack the cells when the oxygen does return to the body. So these chilled cells are able to withstand the shock of restarting cellular metabolism, and cells can then eventually recover to normal functioning. In addition to reducing the amount of harmful ions that build up in the brain after a cardiac arrest, there's a few other ideas for why therapeutic hypothermia does benefit the patient. The first one being that it reduces the inflammatory response that is seen in the brain and the body after an ischemic reperfusion injury. Next, we see a reduction in the intracranial pressure. This is because of vasoconstriction that is experienced when the body is cold and chilled down, and this leads to a decrease in cerebral blood volume, which ultimately reduces the intracranial pressure and decreases the risk for damage to the brain. We also see a reduced cerebral oxygen demand and a slowdown of the cerebral and body's metabolic rate. There's also a prevention with therapeutic hypothermia for complications of brain ischemia, such as edema formation and brain hemorrhage. And lastly, hypothermia is also beneficial because it can prevent hyperthermia and therefore patients from being febrile, which is harmful to the body when it's in this state. Next, we'll look at the process of therapeutic hypothermia. So first is the induction phase, which is rapidly cooling the body. And next is the maintenance phase, which is maintaining the body's temperature at 32 to 34 degrees Celsius. And lastly is the rewarming phase, which is slowly increasing the body's temperature back to a normal temperature. So the first step in the process is rapidly cooling the body. So pre-hospitally as paramedics, we will want to initiate the cooling process within 5 minutes after we receive a ROSC. And in the hospital, this process is recommended to be started 4 to 6 hours after the ROSC, just for the best patient outcome. Before you do this, or while you're doing this, you will want to provide sedation to the patient to help relax them and keep them from shivering. One Canadian study used 5 to 10 milligrams of midazolam to sedate these patients. They actually started with 5 milligrams, and if the patient continued shivering, then they would give another 5 for a total of 10 milligrams. And you will also use various internal and external methods of cooling to get the body temperature to 32 to 34 degrees Celsius. So there are many different methods of cooling the body. The most commonly used are externally chilled IV fluids and the transnasal. So externally, that is by applying cooling blankets, ice packs, cooling pads, or water blankets to the body. And typically, paramedics will apply these to the neck, axilla, and groin of the patient. Then there's also IV fluids that can be used. These IV fluids are chilled to approximately 4 degrees Celsius, and it is injected into the bloodstream of the patient. This is normally done with a pressure infuser, so it goes in quicker to the body, and up to 2 liters can typically be done pre-hospitally in most studies that I found. And lastly is the transnasal evaporative cooling, and this is when a tube is inserted into the nasal cavity and it sprays a coolant mist to the brain and bloodstream, to cool the brain and bloodstream. And this is typically a safe method to be used pre-hospitally, as it's not very invasive and it's very effective as well. So a few studies actually compared the internal versus external cooling devices. So the internal devices being the chilled IV fluids, and they found that these were more accurate in controlling the body's temperature. But they also did have higher risk of adverse effects. Some of these adverse effects being increased risk of infection and bleeding and catheter-related thrombosis. And then when looking at the external devices, they found that they were less accurate in controlling the temperature, and they could also lead to skin breakdown and tissue necrosis. So the next step in the process of therapeutic hypothermia is the maintenance stage. So this is where we want to maintain the body temperature of 32 to 34 degrees Celsius for 24 to 48 hours. Some studies looked at the differences in how long the patient was kept under a cold body temperature, and they found that there was no differences in the survival rates between patients treated for 24 versus 48 hours. However, there were more adverse effects seen when the treatment time was increased. So these adverse effects include hypotension, hemorrhage, pneumonia, and arrhythmias. So as a result, they concluded that a 24-hour intervention seems to be more effective because they avoid the adverse effects. Also within the maintenance phase, you should be monitoring for signs of fluid overload and inadequate sedation or shivering. You should also be preventing long-term complications like bed sores. So the last stage is the rewarming stage, and this is done after the 24 to 48 hours. So the body is slowly rewarmed over the course of several hours, and one study found that it was the most beneficial to increase the body's temperature by 0.25 to 0.5 degrees Celsius every hour. There are a lot of associated risks with therapeutic hypothermia. The first one being an abnormal heart rate. So there can be dysrhythmias, prolonged PR and QT intervals, and widening of the QRS complex. There's also bradycardia that is experienced in these patients. Typically, they will first experience tachycardia, then bradycardia. The patients can also experience infections. So this is because there's an inhibition of white blood cells functioning and the immune response within the body when the body is cooled down. So pneumonia and sepsis were actually seen in half the patients in one study after they experienced therapeutic hypothermia. Another risk is that the therapeutic hypothermia actually increases the risk for bleeding within the patient, and this is because there is a decrease in the number and function of platelets within the body. Next, we see electrolyte and metabolic problems within the patient. So we might see hypokalemia when the patient is cooling and hyperkalemia when the patient is rewarming. And lastly, we can see hyperglycemia, and this is because hypothermia inhibits insulin secretion and decreases insulin sensitivity within the body. Research also shows that there are a list of other uses for therapeutic hypothermia in reducing the neurological deficits that can be seen after these specific conditions. So the first one being a cerebral vascular accident. So studies show that there's a potential for improvement in neurological outcomes after an ischemic stroke. The mechanism is similar to the one for cardiac arrest patients, as I explained earlier. Another potential use for therapeutic hypothermia is in neonatal asphyxia. So this is the lack of oxygen and blood flow to the brain after birth, and this is due to failure in establishing breathing within the baby. And another potential use is traumatic brain injuries, and studies have shown that therapeutic hypothermia can be useful in mild brain injuries as well. So now we come to the question if therapeutic hypothermia actually works or not. So there was a study done between 2012 and 2016 with the Halton, Peel, Toronto, and York Paramedic Services. So they took part in a randomized controlled pre-hospital study with about 585 patients, and 279 of these received the treatment of therapeutic hypothermia, and the rest were the control group who just had normal body temperatures after they experienced their ROSC. And so the results for this study was that they found rates of survival were similar between both groups, and they also found that survival with good neurological outcomes were very similar in both groups. So therapeutic hypothermia didn't cause better neurological outcomes than the normal patients. Another finding that they found was that pre-hospital cooling was associated with a decreased incidence of pulmonary edema. They also found that when they did induce this pre-hospital cooling or the therapeutic hypothermia, they found that the hospitals did tend to continue with this treatment. So ultimately, they increased the number of applications of therapeutic hypothermia within the hospital. So this chart looks at the neurological outcomes between the groups within the study. It rates them based on if they develop a disability and the severity of this disability, as well as if they died post-ROSC or not. So as you can see in this graph, the control group is very similar to the pre-hospital cooling group or the therapeutic hypothermia group. Both percentages all appear to be very similar. There's no statistical significance between both groups. So the green levels, which is where the patient does not develop symptoms of neurological deficits or any significant disabilities. Both of these green lines are similar between the groups, as well as the middle lines where the patient did develop a disability. No differences there as well. That's also seen in the black lines, which is where patients have died after the ROSC. So based on this, the rates of survival to hospital discharge and survival with good neurological outcomes were very similar for both groups. So overall, therapeutic hypothermia is a safe technique that has few adverse effects on the patient. However, it is not consistently shown to improve the survival rate and neurological status for patients. Some studies have shown a clear benefit to therapeutic hypothermia, whereas other studies, like the one I just discussed, show that there's no statistical significance with this treatment. But because there is potential for it and there's evidence that the hypothermia does reduce brain damage, further investigation and studies are still needed. Thanks for listening, and here are my references.